This is Vermont Edition. I'm Michaela Lafrac. Today, we are joined by one of the top leaders in Vermont's healthcare ecosystem, Owen Foster, the chair of the Green Mountain Care Board. It's in charge of regulating hospital budgets and health insurance premiums. Basically, everything that affects the healthcare services you can access and how much they cost. Now, if your job is to run a hospital in Vermont, you and your team have a pretty good sense of how much money you'll be able to bring in the coming year. That's because Owen Foster's organization, the Green Mountain Care Board, just approved budgets for Vermont's 14 hospitals. Those hospitals earn money by charging insurance companies. The Care Board limits how much hospitals can charge to make sure the insurance companies can stay afloat. Everything is in a delicate balance, or it should be. Many Vermonters feel like they can't access or afford good health care right now. Vermonters pay much more for health insurance than the national average. On top of this, local hospitals are cutting services. Owen Foster, chair of the Green Mountain Care Board, we have a lot to talk about today. Thank you so much for joining us.
Thank you for having me, Michaela.
And listeners, as always, you can join this conversation as well. If you have questions for Owen Foster or a story to share about your own experiences with our healthcare system here in Vermont, you can call us at 800-639-2211. You can also email us at vermontedition@vermontpublic.org. Owen, let's start big picture here. You were appointed to this role by Governor Phil Scott in 2022. Broadly, how have you seen Vermont's healthcare landscape change over the past 3 years that you've been in this role?
I think in the last 3 years, the awareness of where our health system is and has really exploded. I think when I got there, I myself did not really appreciate how tenuous the situation was, and I didn't really appreciate how much change was needed. There had been some inklings that there had been problems, so the Care Board under really Jessica Holmes, one of our board members, really pushed for health system transformation starting in 2019. Then you had COVID, and then the legislature passed 167, an act in 2022. But really, the broader awareness of how tenuous things are has really increased dramatically.
And could you also remind us what 167 is? It's a law that really governs a lot of your work that you're doing now.
Yes. So 167 was passed.
Guys.
It's a health system transformation bill that called for the Green Mountain Care Board to produce a report analyzing the status of our health system and identifying opportunities to make it more sustainable. And that ultimately led to what's called the Oliver Wyman Report. And the Oliver Wyman Report came out in September of 24. And it essentially said this health system needs hundreds and hundreds of millions of dollars more a year, how it's currently structured, and you don't have it. And if you want to have sustainable hospitals and sustainable access to healthcare, you really need to change and change fast. Kind of akin to what we're seeing in education.
Yeah. We already have a question coming in from Steve in Jericho. Good one as we're talking big picture here. Steve wants to better understand the board's role in what he calls reducing taxpayer liability for unchecked healthcare costs. So it sounds like Steve is one of those many Vermonters out there who's feeling like healthcare is too expensive. Maybe health insurance is too expensive right now. What is the board's role in reducing taxpayer liability for that?
Right. So taxpayers pay in two ways, really through federal taxes for Medicare and state taxes for Medicaid. The Green Mountain Care Board has no role in setting Medicare or Medicaid rates. That's the Agency of Human Services for AHS for Medicaid, and then the federal government, CMS, for the Medicare. The Care Board's role is really on the commercial side. The connection I think Steve is probably alluding to is if we allow hospital budgets to go really, really high, that can translate to increased local taxes, so property taxes, because the teachers, their health insurance premiums would go up. So if we keep the hospital rates at an appropriate level, that helps control the cost for the teachers and health insurance.
Sorry, can you spell that out for us a little bit more? So if a hospital's budget goes up, how exactly does that affect what a teacher is paying for health insurance?
So, all right, there's Medicare and there's Medicaid, and then there's commercial. And within commercial, there are people who just have Blue Cross Blue Shield from their employer or wherever else it may be. The state employees, such as myself, we get insurance from the state. The state taxes pay for my health care insurance. Mm-hmm. then the teachers, they get health insurance as well. And if the hospital spending goes up really, really high, that means the cost of my health care insurance as a state employee goes up, which the state has to pay for. Or similarly, it can mean that the teacher's contract can go up and what they have to pay for health insurance goes up. If my health insurance goes up or a teacher's goes up, it can translate to higher taxes in the state.
Simple. I don't know why everybody doesn't understand this.
I don't know if I explained that.
No,
well.
that was very helpful. And thank you. As we go through this, I might ask you a lot of those clarifying questions just so we get to the heart of it. Because I know you work with us all very, very closely. Yeah. All right, let's dive into the hospital budgets because that's the most recent decision to come out of the Care Board. So you just completed your annual review of budgets for Vermont's 14 general hospitals. And the big headline here, it seems, is that the board is pushing a major cut in commercial revenue for UVM Medical Center, which is the state's largest hospital. And in a press release about it, you said, and I'm quoting here, GMCB's decisions hold the UVM Health Network Administration accountable for having transferred critical dollars out of Vermont to cover for the network's inability to sustainably operate its New York hospitals. We will not allow the Health Network's administration to use Vermont's limited healthcare dollars to subsidize its inability to obtain adequate reimbursement for its critical New York hospitals. So is the revenue cut you're enforcing here essentially a penalty on UVM Health Network for investing money in the hospitals it runs in New York versus Vermont?
No, it's not a penalty. So let me set the structure because I think it will help. The UVM Health Network is a parent company. It's a corporation that sits over hospitals in Vermont and New York. The medical center is the hospital here in Burlington, and they come before the Care Board and ask for a certain amount of dollars. When they ask for those dollars, we have to look at how they're spending the dollars we've been giving. We approve. We don't give them, obviously. And then we also have to look at how much money they have in their reserves. And what we found was the health network, the parent entity, actually had about $262 million that wasn't being counted in the medical center's reserves. On top of that, what we found was that the health network was taking a lot of money out of the medical center, over $120 million, and using that money to cover costs that were borne by New York hospitals owned by the health network. And so our point was, we can't really give you all of this money if it's not going to be invested in Vermont, because it's Vermont ratepayers that are paying it, and they don't have any more money to give. So the point was really that the health network, the parent entity, needs to adequately and sustainably run its New York operations and can't come to Vermont and take out reserves from our academic medical center to pay for the problems, financial problems in New York. So that was really the point. And on top of that, that parent entity is an expensive operation. And how they fund it is they charge the hospitals, essentially to divide up what the costs are of that parent entity, and then the local hospitals have to pay the bill. And we determined that that was too expensive. We can't afford it, and we didn't think it was necessary.
Can you go back to there was an amount of money that you said that kind of wasn't being considered by the hospital as part of its budget? Where exactly were those funds being held? What were they?
Yep. It was about $262 million that was being held at the parent entity. So that every entity has its own balance sheet. The parent entity, the health network, had $262 million in assets. And I'm not suggesting it was nefarious, but it was a lot more money than was being counted when they report days cash on hand for the medical center. Days cash on hand is a measure of reserves. And if the reserves are low, that's bad because they can't invest and they can't sustain their operations. But a lot of money had been taken out of the medical center and put at the parent entity. And we had a problem with that.
And for folks who are listening and wondering what hospitals are being affected by this, what are under the UVM Health Network, I'm just going to list them real quick because it might be in your community. There's the Champlain Valley Physicians Hospital in Plattsburgh, Alice Hyde Medical Center in Malone, and Elizabethtown Community Hospital. So those are all New York. And then in Vermont, there's UVM Medical Center in Burlington, the state's largest hospital, Porter in Middlebury, Central Vermont Hospital in Berlin, and two home health and hospice networks. So all together with all the hospitals in Vermont, all 14, they submitted budgets that would have led to more than a 2.5% commercial rate increase. But after the Care Board's review, there's going to be, correct me if I'm wrong here, a 2% decrease overall.
In commercial price.
Correct. So how does that work? How are hospitals going to stay afloat if they're bringing in so much less money from insurance companies than they had hoped?
Yep. So most of the hospitals got the budget they submitted. 8 out of 14 got exactly what they had asked for. So they should be fine. The vast majority of the money you're alluding to was pulled out of the budget from the UVM Medical Center and the UVM Health Network. And part of that was because there was additional money being held at the parent company. So they will stay afloat because there's that additional money. And then on top of it, in the budget, they were actually planning to take $16 million out of the medical center's reserves to pay for New York hospitals. And we didn't think that was appropriate that Vermonter money was being invested in facilities that, by and large, Vermonters don't go to. And of course, New York has a lot of larger, far more financially sustainable insurance companies than we do here in Vermont.
Yeah.
So it was $16 million of that money was money being planned to be spent in New York, and we said no.
Okay. So the head of UVM Health Network, Sunny Eapen, came on Vermont Edition about 2 months ago in mid-July. And we talked about some of the back and forth between the health network and the Care Board that's been going on over the past year. And this isn't the only instance where there's been a real discrepancy in what the health network has asked for and wants and what the Care Board decides. For example, last year, the board ordered UVM Medical Center and another hospital, Central Vermont Medical Center, to cut revenue. It issued a penalty after the medical center earned more revenue than from patient care than it had expected. I want to play one clip here from my conversation with Sunny Eapen about what could happen to patient services in the face of reduced revenue.
These are the difficult types of decisions I think that we are going to have to make for the greater good of the entire state and region. We're going to have to make some really difficult decisions. You highlighted Copley closing their birthing center, an incredibly unpopular decision in that community, but I understand the difficult decision that board and the hospital management had to make because for sustainability, they were continuing to lose money on a relatively low volume line of care. And so they have to make these difficult decisions about the greater good of their community in that area. And that made sense. And it was similar to that when we were making those decisions.
Do you, Owen, think that we're going to see cuts to services from UVM Medical Center in light of this hospital budget that the board recently approved?
I don't know the answer to that. I would say probably not, and I would hope not. And I don't think it's necessary, but I haven't spoken with them since our budget order about the particular details. And the reason why I say no, and I don't think so, is because one, they do have those significant reserves that are at the health network and at the medical center. On top of it, there's an immense amount of expenditure at that health network operating level, right? So Dr. Eapen, there's CMO, CFO, Director of External Relations, all those positions, I think, should be eliminated first before we eliminate patient care. So external relations, network administration, that's tens and tens of millions of dollars. And if you're looking at an operation, you should really prioritize patient care, and those positions should be eliminated first, in my opinion.
I also want to talk with you about executive salaries, but we do need to take a short break. So let's save that just a minute. If you have questions for the head of the Green Mountain Care Board, Owen Foster, or thoughts about healthcare more broadly in Vermont, how do you think the system is working for you? Give us a call at 800-639-2211. You can also email Vermont Edition at vermontpublic.org. We'll keep this conversation going in just a minute. Stay with us. Welcome back to Vermont Edition. I'm Michaela Lafrac. Today on the show, we are talking about the cost of healthcare. The Green Mountain Care Board recently approved hospital budgets and insurance premium increases for the coming year. Our guest is the chair of this regulatory body, Owen Foster. And we want to hear from you this hour. Are you concerned about the financial health of the hospital in your area? Have you noticed changes to the services they offer in recent years? You can give us a call at 800-639-2211 or send us an email to vermontedition@vermontpublic.org. And so, Owen, let's get back to this conversation we were having about hospital budgets. One of the Care Board's goals in the hospital budgeting process this year was to protect access to rural hospitals. Do you think you achieved that goal?
Yes, although I would say it's not something that's entirely in our purview or control.
Yeah.
I mean, so much of it is what happens with the Medicaid rates. And the Medicaid rates have been pretty flat for a number of years. And so if we can't increase the Medicaid rates, that's a factor. On top of it, if Medicare lowers their rates or changes their payments, that's a fact. We can't dictate those things. The only real control we have is over the commercial piece of it. And in Vermont, our commercial insurers and our people simply can't pay more for health insurance. So I would say that, yes, I think we did balance that tightrope this year. I'm not overly bullish on the long term in that regard.
Yeah. And we had talked earlier about this complicated, well, not complicated necessarily, but sometimes fraught relationship between the Care Board and the UVM Health Network, the largest healthcare system in the state. And I mentioned that we had Dr. Sunny Eapen on the show a couple months ago. And one of the things we talked about with him was executive pay and bonuses. And this is an issue that affects both hospitals and insurance companies as well. So last fiscal year, Sunny Eapen received a $600,000 bonus on top of his $1.3 million salary. And on our show, he said, that's a competitive salary in his industry. And if you're not offering top executives that kind of money, you're just not going to get the best people.
When you're trying to recruit very good people and you say that we are not going to have that as part of our compensation, it hurts us in our ability to recruit folks. And that's part of the challenge that we're balancing in that space, because we want to do the very best for our community and our patients. And so it has an impact.
And then Blue Cross Blue Shield Vermont CEO made just a little under $950,000 as a salary last year. They're a nonprofit organization. They've been saying for a year they're at risk of insolvency. And then MVP Healthcare CEO made over $1 million with another $1.2 million in bonuses and other compensation. To whittle all this down, does the Care Board have the ability, if it decides it's necessary, to limit executive pay?
In some respects, yes, and we have. We did it this year with Dr. Eapen's salary, and we did it previously with the ACO's salary. With regards to the insurance companies, we only regulate a very, very small part of their business, and I don't think that we do as to the insurance companies. So yes, where we have the authority, we have done so, and we've exercised it. We were appealed. UVM, which owns the ACO, appealed us to the Supreme Court, and we won. And it was clear that we have the authority. And then the legislature this year and the governor passed a law enhancing our ability to look harder at executive compensation. And this year, we did cut the Dr. Eapen's salary and some other executive salaries, yes. And they sent us a letter saying it was illegal and improper, and we determined it was okay.
So is there a chance that they could then sue the Care Board? Like, what could come next if they're alleging it's illegal?
They could appeal to the Supreme Court, and the Supreme Court would look at the statutes and look what we did and make a determination on whether or not we had the authority in that context.
Okay, so we have that to look forward to.
Maybe not.
Potentially. All right.
I think just on that, I heard that quote, and who cares? Who cares is what I say. What I say is, if you demand top dollar, maybe this isn't the right environment for you. Because we want people who are committed to the community, not getting their benchmark or their market, if you will, right? Your market is really driving success for the state, and you should be thankful for the opportunity to do that and not say, oh, I'm only getting the 35th percentile. I don't want to be here. I don't think we want those people.
Yeah. On the lower end of the salaries, say nurses, other healthcare workers as part of the hospital systems, does the Green Mountain Care Board have a role there in figuring out their compensation and how it compares to other states?
No, we have no authority to increase. We only have authority to look at executive compensation, but we do look at the spread. And that was one of the things we looked at this year in looking at the executives at UVM salaries. The spread was growing the last couple of years, and that was part of the rationale behind our decision. But we can't dictate, hey, you got to pay the nurses more. We have in a couple budget orders questioned why the executive raises were such as they were when the nurses were they're being battled when the union goes to negotiate a contract. There's lawyers, there's PR people, there's teams of negotiators trying to keep the nurses' salaries down. And I just find that an incredibly wasteful expense. We need the nurses, and I think that there's a shortage of them as compared to healthcare executives. So I do side on the nurses' side for paying fair wages. We need them critically. I should disclose my wife is a nurse, and so maybe I'm a little bit biased, but I think they're incredibly important to the community. On the executive salaries, I just think it's also a really tough look to cut sensitive services and take giant pay increases. I don't think Vermonters can say, oh, you needed market salary to be here or you'd leave. Well, you cut services and sent money to New York. I don't think that's okay.
Yeah. And on that note, this winter, also UVM Medical Center announced it was going to stop doing kidney transplants. People now go to Dartmouth-Hitchcock in New Hampshire. So just another example of the service cuts.
I would say some of what Dr. Eapen said is right. I mean, we're not going to be able to keep everything everywhere. You asked me specifically about will UVM cut things in response to this budget, and I don't think they need to because of the millions, hundreds of millions of the network, the 16 million we said you can't send to New York, and all the executive and excess expenditure. But that doesn't mean more broadly in our system we're going to be able to sustain everything as we are.
Yeah. I mean, it's an issue of scale, too. I mean, with the kidney transplants, I think UVM was doing 12 kidney transplants a year. Does it make sense to have a kidney program when it's that the patient number is so small?
We can't have everything in our backyard.
Yeah. Let's go to the phones here. We have Betsy calling in from Elmore. Betsy, go ahead.
Hello.
Hi there.
Hi. My name is Betsy Perez. I just closed my urology practice. I've been in Lamoille County for 24 years, serving Copley Hospital, and I was a kind of a dinosaur, private physician the last 8 years. But I just closed my practice because of bureaucratic problems as well as where I am in my life, age 63, and because Copley Hospital closed the birthing center. So I really appreciate Mr. Foster's attitude toward what you just said, who cares? I want to get back to that. I probably over my career made $2 million less than I could have somewhere else because I cared about the community. And I don't understand, and maybe you can answer this, Mr. Foster, because I know that the public can get the information. It is public. The CEO at Copley Hospital makes approximately $700,000 a year. Now, I haven't seen the new budget, so I don't know exactly where it is. The top paid orthopedic surgeon makes $1 million a year. There are 8 orthopedic surgeons for a 25-bed hospital. Why do we not have a 2 or 3 bed, cut down, pared down birthing center? I have some ideas, but I'd like to know what your thoughts are on that.
Thank you, Betsy. Owen Foster?
Yeah, great question. So it's really a bigger picture of putting our money where our mouth is. And if we really, really value mental health care, and I think that we should, or primary care, we need to reimburse it in a sustainable way. What happens is the insurance companies and the hospitals negotiate, and they'll often put a lot of the rate increase on a particular service line, maybe MRIs, maybe ortho, maybe derm, whatever it might be. And then, there's a shortage of money on things like urology or birthing. And I think that we actually need to make sure that there's alignment between how the hospitals and insurance companies are negotiating where to put the money. It needs to be consistent with our state goals, which right now are really focusing on primary care and mental health care and long-term care.
Well, Betsy, thank you so much for calling in, sharing your experience as a urologist with us today. We also have Penny calling in from Fairhaven. Penny, go ahead.
Hi, I'm a nurse, and my question is along the lines of the previous caller. I have looked at the 990 for Rutland Regional Medical Center. Rutland is a relatively small town, and they have general surgeons there earning over $500,000 a year, and they have also orthopedic surgeons there earning over $1 million a year. I personally think that cutting some of those salaries to a more reasonable level for the size of the community we're in would free up a lot of money for care that's needed in other areas.
Yeah, Penny, thank you for calling in. And yeah, we're balancing all this, Owen, and maybe you can speak to this, with a shortage of many types of medical providers. And there are other states nearby where folks like the doctors that Penny's talking about could earn much more than even those salaries, which sound quite high here in here in Vermont. How do we balance that?
Yeah, I think the physician salaries are a little bit different in that you're not going to get top flight orthopedic surgeons unless you are paying market. I think there's a difference between administrators and the physicians themselves. And that is a broader national issue where particular practices get paid a lot more than others. But I do think we want to balance it out so that it is more consistent with our population health goals. And that means we have the robust preventative care and long-term care that we need. And we do need to find a way to pay that appropriately so they're sustainable. We're losing a lot of FQHC practices. Primary care practices are at risk. And if we don't want to lose them, and I don't think we should, we need to find a way to make sure that they're financially sustainable too.
Well, thank you for calling in, Penny. You can call in as well, speak with the chair of the Green Mountain Care Board, Owen Foster, share your own experiences with Vermont's healthcare system by calling 800-639-2211. So let's talk a little bit more about insurance companies here, Owen. So in August, the Care Board ordered Blue Cross Blue Shield of Vermont and MVP to make their premium price increases smaller. It's a little confusing. So they requested a premium price increase. You guys said you could do that, but just much smaller than the request. Vermonters pay higher insurance premiums than pretty much any other state. What if Blue Cross Blue Shield can't cover its claims in 2026 and it goes out of business? Play this out for us. Is that a situation that's really on the table right now?
I think not in 2026 because of some very significant actions the legislature and the governor took this year. And I think we should give them credit for being pretty bold. This year, the legislature passed a bill called H-482, and that allowed for emergency authority for my organization, the Care Board, to reduce hospital prices in a situation where an insurer might be insolvent. So if Blue Cross is below a certain financial threshold, rather than raising more money out of Vermont premiums, we can actually lower hospital prices for hospitals that have a lot of reserves or that have really high prices. So we can actually lower it without raising more funds. And that's sort of what we need to get to, is having this all interconnected, the financial and delivery side of healthcare. It can't just be we always need more money, because that's what it's been, and it does not work. So this year the Care Board took a pretty hard line to both hospitals and insurance companies. And we just said, no, you're going to have to make this work. On the insurance company side, there's a number of things that were happening in the negotiations that were really making it difficult for Blue Cross to have a sustainable reserve level. They were really having a difficult time negotiating with UVM. And UVM, I think, allegedly, according to Blue Cross, was exerting some excessive market power that really changed the dynamics. And Blue Cross, in their opinion, couldn't say no because, according to them, UVM would threaten to walk. And then Blue Cross would be in real trouble to not have UVM in the system. So all these dysfunctional dynamics, and that's, I think, a fair characterization, need to get reimagined in a way that actually serves the people. And I think some of our executives and leadership in healthcare need to take a really hard look at what they're doing and change that.
Well, speaking of shifting the model, we got an email from Ken in Burlington who's wondering if the state has considered chartering its own insurance company that could pool state employees with the other employers in the state. Ken writes, it seems like a lot of money is being lost to middlemen and in negotiations with greedy insurers. This is a model that has worked elsewhere, and the current situation clearly calls for some creativity, bravery, and a solution sufficient to the problem. Owen, are you familiar with this model that Ken's proposing here?
There's a couple versions of the model that Ken is alluding to. The Department of Financial Regulations in the state of Vermont generally is looking at some insurance modeling options. There's also a new payment model that's potentially available from the feds called the AHEAD model that the state is looking at. Right. So there are models. I would caution, though, that models are only as good as you execute and implement. We've had a lot of reform models. They have not worked well. So everyone always wants a new model to be the panacea that will save us, but it's really the implementation and execution of them.
Richard in McIndoe Falls wants to know a little bit more about Blue Cross Blue Shield's situation. He writes, why should hospitals be driven to bankruptcy to bail out Blue Cross Blue Shield for their poor business decisions? They came out of the pandemic with an enormous reserve and were surprised when people needed more health care. Richard calls this a bailout scheme for the insurance company. Do you, Owen, feel like hospitals and patients are having to bail out Blue Cross Blue Shield of Vermont?
It's an interesting perspective. In some ways, the insurance company bailed out the hospitals, and that's why they're broke.
Huh. Okay.
So they're the greedy insurance company rhetoric, I kind of get it. Like there's certainly that nationally. But when you have an insurance company with the reserves of Blue Cross, I wouldn't call it greedy. If anything, they've been giving out too much money to some of the hospitals, and that's why they have a difficult time. So maybe it's sort of a rebalancing in a way, as opposed to a bailout. The broader point I would make, and we were quite critical of some of Blue Cross's practices in our opinion that we published in August, and I think they were appropriate concerns that we raised. But if Blue Cross does go under, your hospitals aren't going to survive either. Yeah. So it's not a bailout for the good of those people. It's really trying to keep the whole system in balance. Yeah.
Can we talk a little bit more about the prescription drug prices and the way that a new state law is going to change those and how that could affect both hospitals and insurance companies? So the governor signed this new law capping how much hospitals can bill insurance companies for outpatient drugs. So those are things like IVs or some cancer treatment drugs. So it sounds like this new law is going to save insurance companies some money, could cost hospitals some more money. What do you see as the other implications of this law down the line?
Respectfully, if you forgot the most important people.
Oh, gosh.
The patients.
Yes.
The patients are the ones who pay the insurance company. So when we have language like, the insurance company versus the hospital, the insurance company is really largely the patients and the people. So I wouldn't call it saving the insurance company money. I'd call it saving the patients money. They're the ones who pay the insurance company's bills and reserves. The way I view all of this is there were extreme price charges on outpatient drugs in Vermont. We were the highest in the nation by a huge margin. Some drugs were Medicare is supposed to pay about 100% of the cost. So we considered a multiple of Medicare, the commercial side. And
How did we get to be the highest in the nation? Sorry.
Yeah, well, hospitals kept charging more and putting more on those prices, and the insurance companies weren't saying no, and it just got out of whack. But what that ends up doing to patients is they pay that, right? So it impacts the amount they pay in premiums, and it impacts the amount they pay in copays. So if a drug costs $100 and you have a 20% copay, you pay $20. If that same drug is marked up to $1,000, you pay $200. And we were seeing extreme cases of what I would call absolute price gouging on our outpatient drugs. And so really this bill made outpatient drugs, cancer drugs, you really shouldn't be charging cancer patients excessive prices. It's terrible. And so I think this actually gives patients a lot more voice and reasonable costs on important life-saving medications. So I really view it from that light. And I am not numb to the fact that it will take away revenue from hospitals. But if your revenue model is dependent on really overcharging ill patients, you need a different revenue model.
And the governor also signed into law a bill that tasks the board with implementing reference-based pricing. Could you explain a bit more about what that means and what you anticipate happening as a result of this law?
Yep. Great question. So as I said, Medicare, the federal payer, essentially tries to pay what it costs for delivery of care. So if a knee replacement should cost the hospital $1,000, they try to pay $1,000.
Okay.
Medicaid typically pays less than that. They might pay 50 to 60% of the cost. And what hospitals typically do is then they make it up on commercial insurance. So they'll charge a multiple of what Medicare charges. So if it's $100 for Medicare and a hospital charges 200% of Medicare, they're charging $200. Okay? And so what reference-based pricing does is it references all the commercial pricing to that Medicare price. And so so Vermont is very, very high at many hospitals for many types of care. And so what we're tasked with doing is lowering those prices to a set level that's a multiple of Medicare. So I'll give you an example. Right now, the University of Vermont Medical Center has the 10th decile highest outpatient prices in the country. That means they're higher than 90+% of hospital charges in the nation for outpatient care. And our job is to lower those prices to a more reasonable and appropriate level. They will lose revenue. But then again, they'll have to look internally, how are we using our money? How are we prioritizing our money? We can't have all these external relations people. We can't have all this additional bureaucracy. We can't have low provider productivity. We need to be more efficient. And so it will be pressure, but we think that it's pressure that's necessary and appropriate to have a sustainable system. Because affordability is access as well. When you can't afford insurance, you don't access a healthcare system. So it's really looking at where are we out of whack and getting it more in line for people to have more affordable care.
We're talking with the chair of the Green Mountain Care Board, Owen Foster. We have to take one more short break here, but we have some great questions from our listeners coming in. We'll get to those in just 1 minute. Stay with us. Welcome back to Vermont Edition. I'm Michaela Lafrac. Our guest this hour is Owen Foster, the chair of the Green Mountain Care Board. It's responsible for regulating health insurance rate increases and the budgets of Vermont's 14 general hospitals. Owen, we've really been getting into the nitty-gritty of these hospital budgets, which were just set for the coming year. And we just got a interesting big picture question. So we're going to zoom back out here from Alan in Craftsbury, who I think has been listening to all this and is struggling with the tenuousness of Vermont's healthcare situation. Alan asks, can we please just acknowledge the dysfunction of the system and plan an orderly transition to a nonprofit, publicly owned, statewide healthcare system? Owen, what do you think of that?
Alan, I will acknowledge the dysfunction of our system. We have been for a while. I don't know about like an entirely publicly owned healthcare system, but in terms of his comment about an orderly transition, that is something that the Care Board has pushed for and the state has been working on for at least 3 years now through that law that we talked about earlier, Act 167, that really is about the health system transformation to try and make this more orderly. And so that when changes happen at hospitals, they're done in conjunction with a broader state plan and vision. So if you're going to lose birthing at Copley, you need to analyze what are the travel times, what are the cost implications, what are the clinical implications? Do we have access at a different place? Will that work instead of having it at both? So you mentioned Copley's Ortho. Copley's Ortho is very, very good. It's high quality. They have good outcomes. Should they be taking more of the ortho cases rather than having a number of places that have insufficient volume? Should be having regional centers of excellence. So the state has been, in the Agency of Human Services, which is in the administration, has been leading that transformation effort since the Care Board released the first report to get us to this step.
Are there, as we think about these bigger system-wide transformations that Alan is throwing out there and other listeners, there are lots of other states in this union approaching healthcare in different ways than Vermont is. I mean, take Maine, which has a very similar demographic to Vermont and an aging population, but their per capita healthcare costs are significantly lower than ours. So do you look to other states and see, is there a model that Vermont could at least partially borrow from in the coming years?
We do, for sure. And a number of things that we find is a lot of it has to do with what are the benefits they're offering. And it's not like they just can pay less and that works. Part of it is that the richness of their plans might be smaller, right? So we've intentionally tried to expand Medicaid. We've intentionally tried to make our commercial plans have more robust benefits. So there's a trade-off in all of this. There's also something called community rating, where we don't, and when we set insurance rates, we don't consider whether somebody's a smoker or whether they're ill. A smoker or an elderly person or a very ill person pays the same amount as a really young, and that influence.
I think the key thing there is in Vermont is the age of the person too.
Correct. So we don't. So there are some changes that, like, we've made policy decisions that this is better for the state. I would say, in my personal opinion, we've also spent a ton of money on things around healthcare that haven't pulled through.
Like what?
The ACO. The ACO was $15, $18, $14 million a year for a number of years, and it really didn't have the outcomes we wanted. It really hasn't been shown to save money. An analysis we did, it net lost money. And so we paid a ton of money and then lost money on top of it. That was an experiment. It didn't work. I would put kind of the health network administrative operations, the synergies that we were promised we would get from that operation, that hasn't pulled through either. It's become more expensive, and we haven't seen the quality improvement that we wanted to either. That's another one. There's a number of these pockets where we've tried to spend money to fix things, but we haven't done the meat and potatoes of getting our system right. They're sort of big, grandiose ideas that we haven't been able to implement well, and I think we need to be very mindful of that. One thing I did want to mention is the Rural Health Transformation Fund that is in the One Big Beautiful Bill Act.
Yes, yeah, it's a fund that states can apply to for a pot of money to help with rural health care access?
Correct. It's a $50 billion fund from the federal government. The application was just put out last week. The state of Vermont will be applying. If you have an approved application, the state was guaranteed $100 million a year for the first 5 years, and then you can apply for a second tranche of money on top of that $100 million if you have an approved application. So there is an opportunity to try and bring in some funds to create some of more of the access and sustainability we want at lower cost, efficient providers that improve population health.
Mm-hmm. Okay.
So the state will be applying for that. I think that would really help with the transformation of what we're doing.
Yeah. Well, at the same time, at the federal level, federal spending on Medicaid is set to be reduced by 15% over the next decade. And it's not really clear yet how many Vermonters are going to be affected and lose their coverage. But some of our hospitals here definitely rely very heavily on Medicaid patients. And I wondered if that was something that you were considering when you were reviewing these hospital budgets for this coming year, or are these Medicaid changes still like a bit too far in the future, a bit too nebulous to be able to to factor in?
Yeah, exactly how much they'll impact Vermont is unknown, and they will not start until 2027. And then they'll be, to the extent there are impacts, they'll be over time. So that part of that is that we're hoping to get this injection of funds to help us set up a system that's more durable and doesn't just need a bailout and more money all the time. We actually need to get the system right so that we're not dependent on more and more money every single year. So that's what the Rural Health Transformation Fund is set to do, to help us deal with potentially a change in the Medicaid payments. A bigger concern for me that's more immediate is the subsetting of what's called the enhanced subsidies, the advanced premium tax credits for the QHP individual market.
What? The what?
Yeah, that's a mouthful. So Blue Cross Blue Shield offers insurance to individuals. An individual who doesn't get insurance from their employer can just go on the website, the Vermont Health Exchange, and buy insurance from MVP or Blue Cross.
Right.
A huge swath of people on that get subsidies in their taxes. So the cost of that premium is significantly lower. That is a federal subsidy. It's a premium tax credit from the feds that you get when you file your taxes. That subsidy is set to expire this year.
Yeah. That's something that like our delegation, particularly, I know Senator Welch has been very concerned about this and
right.
to push back against that change.
And that's a bigger change to me than the potential Medicaid changes over time, because that's commercial dollars and that's commercial lives. So commercial insured people pay more for health care. So the impact on hospital finances will be more if people drop commercial insurance. And for those families to not have insurance or to pay a huge increase is really difficult. So when we were doing hospital budgets and insurance premiums, that was something we were very cognizant of. How much more can these folks pay when they're set to lose subsidies, right? So it was really important that we not have really large premium increases this year.
I know we're talking about things at the federal level right now, but we have just a couple minutes left with you, Owen, and I want to make sure we get to a question we just got from a emergency physician who's practicing in central Vermont. They say they've been there for 15 years, didn't share their name with us. They say that they can't agree more that healthcare is far too expensive, especially in Vermont. They also agree that the UVM Health Network is far too top-heavy and with too much middle management. The network system is not working well. However, my concern, they write, is that using net patient revenue is not a good measure. I would argue that net patient revenue is more reflective of the healthcare product provided. Sicker, older patients cost more, and more of them are showing up, which is why revenue is also going up. And they say then that net patient revenue is, in fact, a terrible measure on which to base expense. What do you think of that, Owen?
Yeah, so net patient revenue, what I think has happened is some of the, I guess we'll call the public relations has said, well, net patient revenue is really just patient care. Mm-hmm. But it's not. It's patient care. It's what patient care. It's medical utilization, necessity, and price. Right? So if you're going really high on revenue, it's not just that you're treating more patients so that they're sicker, it's that you're doing it at a really high price. And if a hospital has an extremely high price and it's going really, really high, well, it needs to lower its price, not say no to patient care. The other thing is we want patients to be in the right care environment. There's a lot of patients that are going to EDs that can be treated in primary care or urgent care. So if NPR, the total revenue, is going up.
You took our acronym.
I know.
NPR means something for you than it does for us.
Net patient revenue. It's the total revenue a hospital is bringing, not the total, but it's the amount of revenue a hospital is bringing in from patient care. So if you treat those patients instead of in the ED in a primary care or a different setting, your revenue will go down. If you keep your population healthier, your revenue will go down. If you treat those patients at better prices, more appropriate, fair prices, your revenue will go down. So I understand the sentiment very, very much, but at the end of the day, there's no way to protect insurers and patients from out of control healthcare costs unless you really look at the top line total amount of money. And we're not trying to in any way decrease appropriate utilization, but we do need to see improved prices. We need to see care being delivered in the right place at the right time. And we need to see ultimately improved population health, which is something we have not seen. We've actually seen decreasing population health. So we want providers like this physician, who I'm sure works very, very hard, and I have a lot of friends at that ED, to keep the people healthier. We want the preventative care to happen so that people are not ending up in the ED. And that's something that we've seen a big problem in the state is a real lack of access to primary care. I do think as we see more primary care and better access to primary care and preventative health, we should see revenue actually go down a little bit.
Well, that's the first time I've heard something like that. That's good news to end on, I guess.
Well, you have to achieve it.
So the Green Mountain Care Board has set hospital budgets or approved hospital budgets for the coming year. It has approved insurance premium rate increases. What is next in the cycle for the Green Mountain Care Board?
We will have an ACO budget review process. The One Care Vermont is sunsetting this year. That will not be part of our review. I don't think it's part of our review this year. There's some new ACOs that have come in. So we'll have the ACO cycle this fall, and then we'll be in the legislative session. I would predict that healthcare will be a very big focus of the administration, legislature this season.
Yeah, even more so than it was last season.
Yeah, and once we finish hospital budgets, we start. So we're working on reference-based pricing right now as well. So these things are all in the AHEAD model. We're evaluating that. So all these things are going on beyond the regulatory cycle. The work to create those. We're starting hospital budget guidance ready pretty soon for the next year. So it really doesn't slow down at all.
Yeah.
And then we are working really hard on the Rural Health Transformation Fund that will be really critical to the state. And I think it's a great opportunity. So ourselves, AHS, and the governor's office are all working together on and the Department of Financial Regulation.
Okay, so big team effort at the state level to make that happen.
Yep.
All right. Do you know when decisions are coming out? Will come out for that, or you're just at the very beginning
of
this application
process?
process?
We have, 4 to 6 weeks to get the application in, and decisions will be by December 31st.
All right.
So very fast.
Okay, lots ahead. We'll be keeping an eye on that. Owen Foster is the chair of the Green Mountain Care Board. Owen, thank you as always for taking the time to talk with us.
Thanks, Michaela.
All right, well, that is all the time that we have for today. Healthcare is a big issue for many, many of our listeners, and it's also a really complicated one to tackle. So this is certainly not the last time that we're going to talk about this year. If you have a specific angle of Vermont's healthcare system that you want us to dig into a bit deeper, or a person in your community who you think is making real effective change in this area, email us and tell us about it. vermontedition@vermontpublic.org is our email. You can also find Vermont Public on Instagram. Today's show is directed by Aaliyah Papes. John Ahrens is our managing producer. Andrea Lorien and Daniela Fierro are our producers, and our call screener is Rick Barrett. Our theme music is by Myra Flynn. I'm Michaela Lafrac. Thank you so much for listening, and we'll catch up again soon.